the whole purpose of today's presentation is to give you a step-by-step strategy so you can deal with upper GI bleeds in the best possible way. And particularly, we're going to frame this in the context of the upper GI bleed bundle, which is a kind of a systematic checklist for junior doctors to really streamline how they manage these difficult cases. On top of that, throughout the presentation, I'm probably going to give you an update of how our gastro service at the Conquest is going to support your GI bleed on call service, especially in the current COVID age. Okay. Now, why is this important? Upper GI bleeds remain a common problem, close the door, for patients managed in A&E and general medicine. So roughly throughout the country, we're probably seeing one GI bleed every 6 minutes presenting nationally. Now, they have a high mortality rate compared to other conditions, up to 10%. Now, there's a misconception that having the gastroscopy straight away fixes the problem. And what I'm hoping to present to you is the case that actually, with good resuscitation measures and using a very systematic approach to addressing your GI bleed, you get better outcomes. Now, as gastroenterologists, we're considered modern-day plumbers of the human body. We sort out leaks, we clear blockages. But the actual ugly truth is that no matter how well we do the plumbing, if there's an issue with the leak and it's catastrophic, no matter what we do, we won't be able to fix it. And really, I'm using these pictures as an analogy that if you have a GI bleed, but you haven't fixed the situational factors surrounding the bleed, such as not giving FFP and platelets to someone with a high INR 3.5, not giving terlipressin for the varicose bleed, not informing the intensive care doctor or the theaters, or not putting up any IV fluids for resuscitation. No matter how quickly I do the gastroscopy for you, it's not going to fix the leak. So really, I can't stress more importantly that addressing all the factors surrounding the GI bleed are actually probably more important than getting your endoscopist at 2 a.m. to come in and do your scope. Yes, we can make a large difference, but if anything, the bigger difference will be with addressing these issues. I'm just going to quickly check if we've got any more attendees I need to admit, so sorry about that, but it's just one of the natures of this system. Right, so moving on, the best way to describe how we do things better or worse is really to present some cases. And a professor of mine quite rightly said that a good way of presenting these things is to show how things can go very wrong or go badly before presenting how you'd like to really do the case. So we have an 81-year-old gentleman who was admitted to Conquest on Tuesday around 8 p.m. He had a one-day history of wake chest pain, and when on admission, his observations weren't too bad. As you can see, he had a fairly decent pulse. Blood pressure was 125/80, respiratory rate 12, SATs 99% on air. His hemoglobin was 80, and the white cell count was 16. No hematemesis, no melena, and he's got no liver disease history, no alcohol history. Because of the vague chest pains, which, I mean, didn't really sound cardiac, he had no radiation to his left arm or the jaw. He wasn't clammy or sweaty at the time. So A&E was a bit worried about a blood clot, so they did a CTPA. There was no pulmonary embolism. There was a large hiatus hernia. They noticed on his ECG he had some T-wave inversions in lead 1 to 3, and it wasn't unclear. He had no previous ECGs to compare to, and his troponin was 76. So the doctors on duty duly started him on aspirin and clopidogrel for what they felt was acute coronary syndrome. So these are his blood tests on admission. So I would say maybe give yourself a few seconds to look at this and tell me, is there anything a bit fishy about these numbers? So, I've got a few people with me just observing. So I'm just going to ask Laura and Isabel as well about what you think. But if you've got a comment, please just put it on the group, actually. So you can message and we can reply to that. So, Isabel, any thoughts about these blood tests? Is there anything a bit unusual about them?
Well, given the context of the talk, the thing that would scream at me is the urea of 31.6.
Yeah, I mean, we know this is a talk about GI bleeds, but particularly even if it wasn't a GI bleed,
Yeah.
These numbers don't correlate very well. He's got a very disproportionately raised urea, despite a creatinine of 107. So he's not, while he's got some AKI, it's not a very severe AKI. And so that just doesn't tally very well with such a high rise in urea. And obviously, you guys know it just as I do because of the topic of this talk, what's going to happen next. His white cell was elevated, CRP was 28, so they did think whether there was an infection too. So actually, they did give some antibiotics as well, but they weren't clear about the source. Guess what? Actually, I think Dr. Muhammad, you might remember this case, but early in the morning, his blood pressure drops to 90 systolic. He looks clammy and sweaty. Still no melena or hematemesis at the time, but the doctor repeats his hemoglobin is 66, so the GI bleed consultant called in. No surprise, shortly after the phone call is made, the patient starts reporting melena. They rush him to theaters. The anesthetic consultants call, but quite late on.
Oh, yes.
Yeah.
I do.
He has a, so,
months ago.
Absolutely. Sorry, I've got Dr. Tiller, one of our gastroenterologists with me. So he has the OGD, but before that happens, and this is quite important, he has a cardiac arrest episode where there's loss of spontaneous circulation.
Theater.
Yeah.
CPR revived.
So basically, at the cardiac arrest, he had return of spontaneous circulation after 2 minutes. They were quick to intubate him, anesthetize him, and then after that, he had his OGD, which showed a large amount of fresh blood in the esophagus and stomach. Really, it was difficult to see anything. So, and that's a big difficulty when you have these large volume bleeds. Even if you put the scope down, very rarely can you see anything that you can endoscopically treat. So you can blindly inject some adrenaline, put some clips, but it's like shooting in the dark. So eventually they had to do a CT abdomen, which showed the evidence of bleeding, and I'll compare those images for you. But the problem was, this is a gentleman who had a massive bleed. He was on aspirin clopidogrel for his ACS. And despite our best efforts, he lost his output. He was elderly, really didn't have much reserve to cope with this amount of blood loss. And unfortunately, he did pass away. This is his CT angio. You can see his stomach, and you can see all this is blood along with a arterial blush right over here. He probably, yes, and Tila is saying to me, he may have perforated as well. So this was a large bleed, probably from a large ulcer, maybe related to his hiatus hernia, but I'm afraid there was no way out of this. Now, so like I say, if you're reflecting on those blood tests, I think the main key here is the recognition. He didn't have hematemesis. He didn't have melena, but he had a very raised urea with a very non-specific chest pain. So the question you have to ask yourself is, could we have picked up this GI bleed earlier? It's a tough one, especially when someone comes in the middle of the night. You've got the reg and the SHO on call, and this happens. So, I think what the message from here is, you have to look at all the different signs to decide if something's a bit fishy about the story. What can we learn? Early recognition of the bleed. You got to look for clues like the disproportionately raised urea. And when you start figuring out, you need to call people early, particularly with these large volume bleeds in the middle of the night. Early notification of the GI bleed consultant on call is very important, because time here is quite crucial. So that's our first case. And now I'm going to go to a case which hopefully I think we've done a bit better, but I'll leave you to decide. And important thing to say to you guys is you can put comments if you don't. You can speak if you want to, but at the moment most people are muted. But if you want to, all you need to do is just put a message on the conversation group, and we can answer that while we're going through the presentation. So this is a different case. This is a 45-year-old lady who's Polish and unfortunately had undiagnosed hepatitis C for many years until she developed some ascites, and we did her serology and she was positive. We think she may have caught it from a family member, but it's unclear because she had no previous intravenous drug use history or anything like that. So she had presented with hepatitis C and liver cirrhosis, and then had a large volume hematemesis and melena, which is what brought her in. She had a grade 1 encephalopathy, slightly tachycardic, a lowish blood pressure, maintaining a SATs on air. In A&E, the A&E registrar was very quick to recognize this was probably a varicose bleed and gave her antibiotics, IV telepressin, a Hartmann's fluid challenge, 500 mils over 15 minutes. Blood was cross-matched very quickly. They did the Glasgow Bashford scoring, which was extremely high, and they referred to the medical registrar straight away. Upper GI bleed bundle was completed quite promptly. The GI bleed consultant was notified, and because this was a high-level bleed that would probably need someone to be intubated to get good anesthetic and endoscopic control, theatre coordinators were notified, booking forms were filled up, the anaesthetist was notified, and the registrar for ITU was called as well. Outreach was notified. So a very rapid progression of escalating. All this was probably in the first half an hour to 45 minutes, actually. These are her bloods at time. So she had a rise in the urea, not as much as the previous gentleman, but HB had dropped to 59. So this was a very large volume bleed. And on top of that, her INR was 1.7. So she was having FFP at the time. Luckily, at the time, her platelets weren't very elevated. So we performed the scope in theaters, and essentially what you can see here is a esophageal varix in the left picture, which I duly banded. This is a stomach. This is the scope on retroflexion. So it's turned around to look at the fundus. And what you can see is, well, there's a bit of blood, but I couldn't see a varix there as far as I could tell. A lot of bubbles. Anyway, varix was banded, so hopefully job done. But guess what? 2 days later, she has another drop in a HB, a large volume rebleed. We go back in. And now you can see it in the same area. If you compare, this is the fundus in retroflexion. Now, with the hindsight, you can see there's a large gastric varix that was hidden by the blood that you can see here. And unfortunately, this was not picked up on the first one, which goes to show you the dangers of not having a very clear stomach to look at. And this is a little fibrin clot just where the varix probably bled before. So these were glued with histoacryl, which is really super glue, which you inject into the gastric varix to let it harden up. Well, we thought we'd done the job, but another day later, she has another massive rebleed. And on this occasion, I do the OGD in theaters. There's a massive blood clot the size of a football in the stomach. I really can't see anything to treat. So we put in a Senstaken Blakemore tube. She's admitted to ITU. We refer her to the King's Liver Unit ITU, and she's transferred the next day. She undergoes a TIPS, which is a transhepatic portosystemic shunt. That basically crosses the veins, and essentially that offloads the portal hypertension pressure and stops the variceal bleeding. She makes actually a miraculous recovery, considering this is all really cutting things really finely. And she's discharged 10 days later from King, started on a hepatitis C treatment, and I've just called her a few days ago and she's well back at home. So this is a really good result for what is a very difficult liver disease bleeder. So what went well? I think A&E recognized the bleed very early on. There was quick notification of the right people, and the resuscitation was prompt. It was appropriate. And more importantly, because they used a bundle or checklist, it was very systematic. They knew what they were doing. So really, the take-home message and the golden rule when you do any presentation is you tell the audience what they need to know at the start, what they need to know in the middle, and what they need to know at the end. And really, what I'm trying to say to people who deal with upper GI bleeds is have a system and use the upper GI bleed bundle, which is what I'm going to show you next. So the upper GI bleed bundle was designed by the various gastro societies to deal with the problem of inappropriate bleed management. So we're just going to add this person on. Brilliant. So essentially, it is a checklist with a very systematic pattern of how you deal with GI bleed, starting with the 6 R's, which is recognition, resuscitation, risk assessment, treatment, referral, and more importantly as well, review after your endoscopy. So this is a very nice streamlined system, which I recommend, and in a way I almost want to say it's mandatory for anyone with a GI bleed. Someone, whether it's A&E or the medical team, needs to fill this up when they have a valid, credible GI bleed that needs sorting out, because this streamlines the pattern and gives you a very important quality markers that we need to address. So we're going to start with the context. I mean, why is this important? Well, if you look at this graph, particularly on the weekends, mortality goes up for GI bleeds. So this is very relevant in this time, as in, you know, you've got less doctors on the weekend. You need a stratified, streamlined system to make sure you deal with this. Obviously, we do have more doctors now as well, but it really doesn't hurt to actually have a good checklist to deal with this. And so the upper GI bleed bundle was created with all these various guidelines and gastro societies involved. And we know it's important because our own audit showed that mortality, while it's improved slightly, is still quite high for upper GI bleeds at 10%. Remember what I said before, you do need an endoscopy to establish a diagnosis and treat it, but not to manage the patient. So very often, I think the biggest problem we have as gastroenterologists is we get the phone call from the A&E or medical doctor saying, please come down straight away, you need to scope this patient, but with very little prioritization about the initial resuscitation. And I think that's what we're trying to shift the paradigm to, which is when you see that patient, remember that it's all those factors, the INR, the appropriate resuscitation, that probably will matter even more greatly than just having the scope. So if we focus on the first 3 R's of the bundle, the first one is recognition, because if you don't recognize an upper GI bleed, you won't be able to treat it. Now, yes, if it's hematapesis, melena, or coffee ground vomiting, those are very clear cut. But occasionally, like with the first case, you might have to look for other more subtle signs like the very disproportionately raised urea with a slightly non-specific chest pain kind of background. Second part is resuscitation. You want to make sure you do the right observations to see if this is a high risk, if they're hypotensive. You commence IV crystalloid, and you give them some blood, but within a restrictive context, and we'll talk about that in a bit. Risk assessment. Glasgow-Blatchford score is now the bona fide score to use in this setting, and we can talk about other scores as well in a bit. Now, transfusion of blood is a big factor in these cases, and before this, it wasn't very clear exactly how much blood you should give, but this very pivotal study from Spain, in which they had a restrictive strategy compared to liberal strategy, was very, very telling. As you can see here from the 2 curves, if you transfuse on a more restrictive strategy, aiming for a HB of more 70 to 80, you have less death compared to if you're giving blood willy-nilly. And so this evidence base has changed the way we deal with upper GI bleeds in the last 5 years, whereas we tend to give blood to aim for a target of about HB of 70 or 80 rather than going for high numbers of 110. I think that's an important point, particularly this cohort, we could see the mortality improvements even greater for those with liver disease. So I think that's a very big take-home message for a lot of people. This is just a message saying if you got a high-risk Glasgow-Blatchford score, you know, you don't even need the score normally to decide someone's really sick. You can see it based on the fact they're clammy, they've got low blood pressure and everything else. What score to use? Well, you've heard about a lot of different scores. Rocco score, Blatchford score, AIM65. And the good news is there's a lot more research going into this in the last few years as well. And what you can see on this graph, which is quite useful, is the area under the curve. It shows you how accurate and effective this score is for teaching you whether this patient is going to have depth or need for a scope. And you can see actually the Glasgow-Bachelor score, which is this blue line, definitely outperforms all the other scores, including Rockwell and AM65 in terms of predicting mortality and the need for intervention. So really, this has changed our gastro perspective about which score to use. We normally recommend now using the GBS. Fine, you can use the Rockwell, but the GPS Glasgow-Bachelor score usually predicts things much better. Other important reason for the Glasgow-Bachelor score, apart from the fact that it's quite easy to calculate, is particularly patients in acute admission unit or those in A&E with a Glasgow-Bachelor score of 0 or possibly 1, you could probably consider them for early discharge rather than staying in for an OGD. So I think that's an important thing to recognize as well. That's another use of the GBS. So really, the bundle has those elements that are very important. This second part of it talks more about the treatment section, which is, if you got varicose bleed, it's important that you recognize that there's a slight differences in management, including terlipressin for the varicose bleed and antibiotics. One thing you guys might not be familiar with is now current guidelines suggest we continue aspirin. I'll talk about that in a bit. But you would suspend all other antithrombotics such as clopidogrel, prasugrel, warfarin, or all the DOACs. You refer to endoscopy within 24 hours of presentation, but we'll talk about when you should be scoping these patients and when's the right time. And more importantly, this part gets forgotten in the midst of things, is making sure someone reviews what the endoscopist has done and starting them on treatments and deciding whether they restart their warfarin or anticoagulation later. These are all very important parts of this bundle and part of actually treating your patients very well. Now, a lot of you say aspirin, that's interesting. Well, the data shows that actually continuing low-dose aspirin in a bleed actually probably does not increase rebleeding. If anything, what we've noticed is a lot of people are getting heart attacks once we stop aspirin. So really the general intention now, unless the bleed is terrible, is to consider continuing low-dose aspirin throughout the admission, because you do probably more harm with these patients from a cardiac side if you stop it. You can stop clopidogrel, but our general rule, unless the patient is really hosing out, is to continue on aspirin. The second question I always get asked is, when should you call the on-call endoscopist? And there is no set rule. You call them when it's important to know that these patients need a scope. That we definitely don't want to know them late, but when should the endoscopist actually come in to do the scope? That's a slightly different question. So everyone has this idea that the second the patient comes to the A&E, you should get a scope. And the honest truth is if you look at the data, mortality goes down if you're scoping around the 12 to 36 hour window. So frankly, if you scope too early, you're probably doing them a disservice too. Now, you have to read this in context. This is for peptic ulcer bleeding. In a varicose bleed, scoping earlier probably may make a difference. But really the take-home message here is resuscitate these patients in the first 12 hours, observe their response, rather than thinking you need to scope them straight away. Whereas if you scope them within 24 hours, that sweet period is where probably the gastroenterologist can do more benefit. So think about that. And this is just really emphasizing the same point about things. The kind of bleed also we see does affect whether they're likely to bleed more, but this is more for something that gastroenterologists see based on the Forest classification for ulcers. So depending if you're an active bleeder, your rebleeding rate is higher and you need endoscopy, whereas if you've got a clean base, the risk of the ulcer getting worse or rebleeding is much lower. And this is what we normally see in most cases actually. For most endoscopies, we would prefer to see a clean base, which is a usual case where we don't normally need to treat it and the risk of rebleeding is much lower. So most patients with a high rebleed risk would be in the higher Forest category where you have active bleeding vessels and you need to treat those. And we can try a lot of different tricks now. If anything, over the 5 years, our ability to treat bleeders has advanced. So we normally would go for dual therapies where you either inject it with adrenaline, you can apply heater probes, but now we have over-the-scope clips as well, which are really massive chunks like bear traps that can clip a lot of mucosa. And we've got hemospray as well, which reacts really well. For a gastroenterologist point of view, the data shows that if you only use one modality, you tend to have a suboptimal response, whereas if you have two treatments like adrenaline and a clip, or adrenaline with a heater probe, the chances of rebleed is much less. So dual endoscopic treatment is the way to go for bleeding peptic ulcers. We can use hemostatic sprays like hemospray now, which is the spray and pray approach, which is very useful sometimes if you've got bleeding that just can't stop. And that works on the basis that the matrix that's formed provides a barrier to stop the bleeding. It doesn't work for everything, so normally it's combined with standard endoscopic therapy, and you find that the rebleeding rate is less if you do that. Cost of failed hemostasis, as you know, if you don't do this properly, they end up having another endoscopy, and that can affect mortality as well. So just to add a bit more flavor to this, we're going to talk a bit about a very common question I get from both consultants and junior doctors, which is, Dr. Fong, do I give a PPI before the patient has endoscopy or not? So joining me are both Isabel, one of our FY1s, and Laura, our FY2. We're going to do a quick debate about whether we should or not give PPIs to these patients. And Laura is advocating for the FOR PPI. So I'm going to... oh, sorry, Isabel's going to go for 4. So I'm going to bring her to the screen now so she can present her case for that. Okay. So thanks a lot, Isabel. Floor's yours if you want to convince our audience whether they should give a PPI before a endoscopy for GI bleeds.
Okay, hi, my name is Isabel. I'm going to talk about why we should give a PPI pre-endoscopy. So this table just sums up a paper by Lau and his colleagues, which demonstrates that in the high-dose PPI group of patients, a statistically significantly lower proportion of them required endoscopic intervention following the PPI. If they did have endoscopic intervention, then there was a lower proportion of patients who had active bleeding on endoscopy, and a higher proportion of patients had clean-based ulcers on endoscopy compared to placebo. This is important because obviously they weren't bleeding anymore, but also it makes it easier for the endoscopist performing the endoscopy to make a diagnosis and target any area that could bleed for therapy. This also just sums up a systematic review of randomized controlled trials of 2,223 patients, which again shows what that study showed, that there was a lower rate of endoscopic intervention and of stigmata of severe bleeding. There's also been a trial that's linked pre-endoscopic PPIs to shorter hospital stays by Chan and Keane in 2011. So based on this evidence, I would say that you should probably use a PPI pre-endoscopy.
Okay, thanks,
you.
Isabel. Yeah, that's we've got some critical points here. Good. So we next have Laura. Laura's going to present and try to convince you that you shouldn't give PPIs before endoscopy, which is actually what our old NICE guidelines from 2012 actually say. So go ahead, Laura.
Okay. Okay, so I think I ended up actually referencing, I didn't put them on the slide, unfortunately, but I think I ended up referencing the exact same study by Lau et al. In 2007. I think it was this study that was one of the first, as well as a couple in the 90s, that ended up really looking at the efficacy of PPIs prior and post endoscopy. And I think that was the big one in 2007 that really developed the controversy, because it did show that people who had PPIs pre-endoscopy ended up, whilst they had the endoscopy and the images taken, that they didn't have the same stigmata of hemorrhaging. But at the same time, they also found in that study that 80% of the ulcers, or the patients that they assessed before they even had endoscopies, ended up spontaneously clotting, and they actually didn't need to be in the study, and they ended up not rebleeding. There were also some studies that were released shortly after that showed that PPIs are not necessarily as effective if the ulcers aren't specifically gastric in origin. So you can have a lot of bleeding esophageal ulcers, bleeding duodenal ulcers that can cause upper GI bleeds as well. But the important thing that they did show from the studies is that they do improve ulcer healing. It's just that it may not necessarily help pre-endoscopy. And the reason for that is that some of the things that they wanted to look at in this study and some other studies later is whether or not they were statistically significant to improve. And I've got a few things on the screen. So it didn't actually help mortality in 1 month. It did not help rebleed risks in 1 month. It didn't decrease hospital stay at all for patients that would normally be predicted to be in hospital for a minimum of 5 days as a result of the type of bleed that they had. And it did not help them avoid surgery either if it was particularly severe and if they needed it. I think part of the controversy as well was that the study that was done in 2007 by Lao was conducted somewhere in Asia, where they have a completely different healthcare system and maybe use the PPIs differently, and the nursing support is different there as well. And I think people were a bit hesitant at that time as to whether or not it could be completely transferable information to other countries like the UK. Luckily, they did end up repeating the study a little bit later in 2017, and they did this both in America, I think a little bit earlier, but they did this actually in England with the British Journal of Pharmacology, and they ended up saying that yes, pre-endoscopy, it does help the pictures and the way it looks inside the stomach, but when you actually look at the mortality and morbidity rates long term, it doesn't really help. And there's a Scottish intercollegiate guideline network, which is another set of guidelines in addition to NICE guidelines. That's a gastroenterology hub that looks at these things as well as the British Society for Gastroenterologists that ended up releasing guidelines similar based on these studies, saying that PPIs are very important because they do help in a chronic sense to improve the ulcers long term. But given that a lot of them clot themselves if they're quite mild or if they have really good scores pre-endoscopy, PPIs, of course, with any medicine will come with side effects and may not actually be that beneficial. And if, again, it's a risk-benefit thing. The only time NICE and BSG said that you would seriously consider giving PPIs pre-endoscopy is if you were somewhere in a hospital quite remote and the bleed was very, very severe and you felt that you really were not going to have access to an endoscopy for, say, a day or two, and you felt that it needed to be immediate. And often PPIs end up being prescribed for patients with upper GI bleeds because they panic or because they haven't done the scores and they feel that it won't hurt them, so they want to give them something anyway. But the studies show that actually it doesn't really do much statistically significant wise. So it's just a few important things to think about. Thanks for listening.
Thanks, Laura. That's really helpful.
Here's your chair back.
Strong points both sides. So this is a tricky one. If I try to summarize it, so no data shows any change in improvement in mortality if you give the PPI before the endoscopy. But as endoscopists, both me and Dr. Muhammad know that sometimes there's less for us to deal with on the endoscopy. So is that a good thing? Is that really worth it for giving the PPI? That's a tough one. So what I might ask you in the audience is actually what you guys think. If you can, just so I've got a rough idea of whose argument you've been more convinced by, can you put on the conversation group if you're for PPI pre-endoscopy or against PPI pre-endoscopy? So if I give you a few minutes of that, just it'd be good to see what the audience feels about that. Let's see, we'll have a few messages. So one good trick about doing these grand rounds is you should always have another phone logged into the actual Teams, because what you find with that is that you can see the messages. I always find that that's something new that I've learned, is that that's a good way of actually seeing what people have responded. So let's see what Johannes has said. So Johannes has said give some PPI. That's quite common thing as well. I think the way I would suggest it is this: there shouldn't be an indiscriminate policy of giving PPI to everyone who has a suspected GI bleed. I think the rationale to give a PPI pre-endoscopy should depend on the senior clinician or experienced clinician dealing with the actual patient they have, and so it's individual choice. There are a few factors that are very important to say. Number one, when coronavirus hit, that did have an impact on the number of cases that we could do. So essentially, instead of being able to do 10 gastroscopies in a list, we can do 5 because of PPE changing and aerating the room, because it's aerosol generalizing procedure. But despite these challenges, we still aim to scope our patients' GI bleeds within 24 hours. But I think that's important to put in context, because latest guidelines for Asia Pacific and other American guidelines have a slightly softer stance towards PPIs pre-endoscopy. They say that if there is a potential for delay, to consider it. So my take-home message for you guys is you don't have to feel that you have to choose one way or the other, but I think don't go for PPIs for everyone. It makes a different case if you think your patient is not going to have his OGD within the 24 hours. It may be reasonable to give it. It may even be reasonable to give it if your patient has a long-standing history of peptic ulcers and has had 2 or 3 bleeds before. Then it's common sense. You do give the PPI because that's the most likely etiology. But when you're not sure what's the cause, but you are able to get a scope fairly quickly, then you should probably not think about giving the PPI straight away. Okay. This last slide, which I didn't mention earlier, just shows that in certain cases where there's no randomized controlled trial, oral PPI may sometimes be just as effective as IV PPI. So it's quite interesting study where they've actually looked into patients on oral PPI, and the outcomes weren't too bad. That doesn't mean everyone here should go straight away to oral PPIs, but it just gives us a bit more reassurance that after a few days of IV PPIs, you could probably switch to oral without too much risk. So if you're going to summarize it all, I think this is probably the best way. This is a very nicely put up infographic of the bundle. Do your recognition, look whether they're vomiting or there are any signs of a bleed. A resuscitation, check the OBS and everything else. Make sure you start intravenous fluids, and after that, aim for a restrictive hemoglobin target of 70 to 100. Calculate their risk score for the Glasgow-Blast. You could consider an outpatient OGD. Treat them appropriately. If it's a varicose bleed, you need IV antibiotics and telepressin, and you can continue aspirin in most cases, but stop all the other antithrombotics. Refer quickly. One thing I always find is a issue is, particularly for patients who get admitted to the medical admission unit at 8 p.m., the SHO sees them and says it's a bleed, but doesn't need to be done today, but done tomorrow, but they don't submit the endoscopy form on the same day, and they leave it in the notes. So my advice is, if you're seeing a patient on the take, bring the form to endoscopy. We have a little letterbox in the endoscopy reception, even after hours. You can just get in there with your ID card. You put it into the letterbox. So the first thing in the morning, the endoscopy nurses can check the referral and get it booked in. Whereas if you leave it in the patient's notes and someone sees the patient on the post-it ward at 11 a.m., and then they submit the form, you've lost valuable hours. So don't forget to put in the endoscopy form and inform the endoscopists, especially overnight, if it's a severe bleed. And lastly, review properly. Review the report. If the endoscopist says put the patient on continuous high-dose IV PPI, you do that. Don't just assume that the endoscopist has fixed the problem and your patient will be fine. Review the antithrombotic plan, particularly for those with high risk of liver disease or heart disease. Do they need to restart warfarin or anything else, or for this, or clopidogrel for the stents? Always involve a cardiologist if you need to. So remember the bundle, because that's going to make a difference, and they're already using it in a lot of parts up north. And the important thing about that is where they've used the bundle, they've seen a dramatic improvement in the length of stay as well as in deaths. So I think this is really the way forward, is using the bundle. And so if there's any take-home message you want to take from this, is use the bundle, use the bundle, use the bundle. But don't forget to use your own clinical acumen to manage the patient in front of you. The bundle is only a guide. You have to see the patient in front of you to see what is the best strategy. And so that is really the nuts and bolts of this presentation, and hopefully it will give you a better understanding of how to manage your upper GI bleeds in acute setting. And that really finishes the presentation for me. So thank you very much for listening. And I'm really open to any comments that you want to say now. Now's Q&A before we end, really. While we're waiting to see if there's any comments, I don't know. Isabel, are you still going to go for PPI pre-endoscopy? What do you think?
I think I'd use my clinical acumen to.
That's a good answer.
It was necessary.
That's a good answer. And Laura, are you still sticking to your guns about not to give a PPI? What do you think?
I think if they're probably mild, then not. But if it's severe, obviously I'm going to escalate and ask for some help.
That's a good idea. I think asking for help is the most important. A few things. Johannes says coffee ground vomiting a real sign. Not always. Melina, it's a much more accurate sign of a bleed rather than coffee ground. Because elderly people with gastric stasis have very retained food products that look like coffee ground. So it can be misleading whether they're true bleeds. So you have to look in the context. If he's not had a HB drop, he's well otherwise, it may not be a bleed really if it's just coffee ground vomiting. To just moving on, for a few things is worth you knowing from a gastro side. So we still maintain a GI bleed service from Friday, Saturday, Sunday. But between Monday and Thursday, we don't have an overnight service, but we aim to scope your bleeders first thing in the morning. So we still maintain a service as best we can given COVID times. Our gastro inpatient referral service has changed to an e-searcher list now. So if you've got any questions about that, you can ask me and I'll be forwarding an email about how the best way you can use that. And lastly, we're going to carry on with a very regular grand round rotation. So we have two really committed SHOs who will be coordinating a grand round. And I really recommend that if you guys can, particularly consultants, if you can volunteer for sessions. We're going to have now a new system with a rolling rota of different specialties. And we will ask and be approaching all consultants to nominate someone for those slots. So we will give you a date. And while you may not need to do the presentation yourself, but if you can allocate a registrar or team to do it, that'd be great, because that will keep this grand round system going so we don't have too many gaps. If there's anyone else with any questions, you can ask them now. But if not, that's the end of the session. And I'm very grateful to everyone who's attended.